the mic to Dr. K. Raghu. So, my dear colleagues who have been with us in this journey of Medanta Echo and Cardiology for the last 10 years, I welcome you all. Strange circumstances have made us meet virtually or by webinars, something none of us actually would like. A face-to-face meeting is a face-to-face meeting. And firstly, I start with thanks to Dr. Zaman and Dr. Raghu and Dr. Agarwal, who've been with me year after year from their extremely busy schedules, coming down by attending the sessions and going away and giving us all, because we learn from every faculty member, we learn from delegates, we learn every day. Dr. Raghu, my good friend, is the president-elect and chairman of the Indian Academy of Echocardiography, which we've all nurtured for many years, and it is safe in his hands. He's a very dynamic personality, and good thing about him is that he's a clinical cardiologist who also does a lot of invasive and echocardiography work. So he has that holistic look at what's going on. And he will chair the session and will take you forward. But I will take 2 minutes to just very briefly introduce two other very good friends of mine. Dr. Asfar Zaman from a beautiful city of Newcastle upon Tyne, which I had the good fortune to visit, and he was very kind enough to host me and my daughter. Actually, we went down there. He's the chairman of the Freeman Hospital for a fairly long period of time, and done pioneering work. I think you were part of the Ischemia study also, weren't you? And the Cantor study. So whenever he comes, it's a question of meeting a person who has been through it, who knows the pitfalls, who knows the advantages. And that's what he will discuss today for our good. Dr. Rajiv Agrawal has been a very dear colleague, really. He and I frequently talk to each other, Meerut and Delhi. We talk about so many things. And as usual, these three gentlemen are the pearls of my conferences, and they are my good friends. And Dr. Rajiv, at this young age, is the chairman of a major hospital, and is doing a lot of good work in vascular biology. And with these brief words, I'll hand it over to you, Dr. Raghu, to take the proceedings further and take a step back and listen.
Thank you, Dr. Kashiwal. As always, I look up to you, and hearing some kind words from you just does make my day. You've been quite flattering to me, and now since it's already 3 o'clock, we are 1 minute past 3. I invite Dr. Asfar Zaman. I'm sure everybody is waiting very eagerly to listen to him and get a perspective of a path-breaking trial, the Ischemia trial, which really has done wonders to invasive cardiology in terms of improving our understanding of which person to intervene. So I invite Dr. Asfar Zaman to start his talk on the management of stable angina as we see it today after the Ischemia trial. Dr. Zaman, over to you, please.
Great. Thank you, Dr. Raghu. Thank you for the introduction, Dr. Kashiwal. It's a pleasure to be here with you in such esteemed company. Can I just ask, are you able to see my screen?
Yes, we are. Please go ahead.
Okay, great. So the title of the talk is Management of Stable Angina. Where does the Ischemia trial lead us? And as usual, what I don't want to do is just to go through the trial bit by bit, but I want to put it into context with all of the other trials and tell a story and the direction of travel of how we manage patients with stable angina. So a couple of background slides. So atherosclerotic cardiovascular disease, we know, is inexorable. We can give medication to try and stop progression, but there is nothing that we know of at this moment that can reverse the disease. But this is where the great amount of research is going on, is how we eradicate this disease. The word stable angina actually was replaced at the ESC last year with chronic coronary syndrome, recognizing this inexorable nature of growth of atherosclerotic cardiovascular disease. And we know that lifestyle and therapeutic interventions can slow disease, and that there are numerous pharmacological interventions to improve both symptoms and prognosis. So atherosclerotic disease has essentially two phases. And this phase, this purple line that divides this in the middle, divides the phase where it's dormant, where the atherosclerosis is growing from a normal to a fatty streak to fibrous plaque to atherosclerotic plaque. And what we're talking about in stable angina is this phase of growth that leads to symptoms of stable angina, intermittent claudication. And it's very important that we understand that this talk is going to be about the disease condition to the left of this line, because the disease condition that takes place when the plaque ruptures is very different. The acute coronary syndrome that we see in cardiology is a very different animal to that of stable angina. Prior to the ischemia trial, there had been meta-analysis of numerous revascularization versus optimal medical therapy studies. And if you look at the meta-analysis, they had all tended to favor medical management in terms of MACE events, but not one had shown significant benefit, but it had all favored medical management. And these were all old trials before we had optimal medical management of the style that we have today. As I said to you, it's not just about the ischemia trial. We have to look at the ischemia trial in context with all other previous trials in patients with stable angina. I'm briefly going to touch on some of these. So the COURAGE was, once again, up to 3 vessel disease. The anatomy had to be suitable for PCI in patients with class 1 to 3 angina. And there had to be objective evidence of ischemia at baseline. And this objective evidence was spontaneous STT changes, ST deviation on treadmill, or imaging defect on ischemia. And briefly, the results showed that there was no difference between the revascularization group compared to the optimal medical management group. And the survival free of death from any cause or myocardial infarction was the same in both groups. But the important thing is that this study went up to 5 years and mean, and up to 7 years in some patients. If you then look at the Orbiter study, which also was presented last year. So this was a blinded, randomized, and for the first time a placebo-controlled study in this patients with stable angina, single vessel, greater than 70% stenosis. And interestingly, there was 6 weeks of medication optimization followed by non-invasive testing, and then randomized 1-to-1 to PCI. And the key take-home message here was that after 6 weeks, there was no significant difference in the primary endpoint between the PCI and the optimal medical management group. So that's the background for the ischemia trial. Now, it's important to realize that one of the criticisms of all of these trials has been that we have taken low-risk patients. And what this graph tells us is that if you look on the left axis of percent of patients who will die and have events of MI or non-ST elevation ACS, and you look at the ischemic myocardium burden on the x-axis, and then on the right-hand side, you look at the atherosclerotic burden, you can see that the greatest risk of dying, having an MI, or having a non-ST ACS is those in where the atherosclerotic burden is the highest and where the ischemic myocardium percentage is the highest. And if you look at the red bar at the back, you'll see that patients with the highest atherosclerotic disease burden, patients with multivessel disease who have the highest ischemic myocardium, have the worst outcomes. So what the ischemia study did was to look at this higher disease burden patients. Once again, stable coronary artery disease, and these were patients who had moderate to severe reversible ischemia or severe ischemia on exercise tests. So this was, the ischemia study was going one step further from the COURAGE study, one step further from orbiter and looking at patients with severe ischemia. There were some usual exclusion criteria that we have in all of these studies. And the most important one, of course, is the point I made earlier, that patients with acute coronary syndromes are a different beast. And so these patients were excluded. This was the population characteristic, and what I want to highlight is merely the diabetic population, which actually marries the sort of percentages we see in the Indian population, where you have patients with ischemic heart disease that have diabetes of around 40%. In the UK, this figure is 25%. There was a heterogeneity of treatment effects for the primary outcome. And once again, what I have tried to show here is that if you look at where the invasive strategy tended to be better was in those with severe baseline ischemia, those with multivessel 3 or more vessel disease, and those with stenosis of the proximal LAD. So you can imagine that if this study had perhaps studied patients for longer, that these were the very, very high risk patients that may have benefited from an invasive strategy. So where does the ischemia trial lead us? Because overall, there was no difference. Optimal medical therapy in patients with severe ischemia was as good as interventional strategy. So the summary for the ischemia trial was that patients with stable angina with moderate to severe reversible ischemia can be safely managed with a conservative strategy. That is the take-home message. And by following the trial selection and management, you could reduce invasive management from 96% to 26%. And you can reduce revascularization from 79 to 21% without affecting the composite of death, cardiovascular causes, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. And that is a really important figure for the health economy. You can reduce invasive management and you can reduce revascularization. But it's not just about a revascularization. The question that Dr. Agarwal or Dr. Raghu asked about, can we reduce invasive investigations? Well, that's also important, because if you want to reduce invasive revascularization, you have to also try and reduce invasive investigations. And the most pertinent study of this was the MR-INFORM study, which was reported in the New England. And the hypothesis of this was that initial management of patients with stable angina with intermediate to high risk of coronary artery disease receiving optimal medical therapy is not, MR perfusion imaging is non-inferior to invasive angiography. And once again, these patients were Canadian cardiovascular score 2 to 3 stable angina with either 2 or more risk factors or a positive treadmill test. And the randomization was to invasive angiography with coronary physiology versus stress MR. And once again, the results were very, very clear that in guiding initial management of patients with stable angina and intermediate to high risk, both FFR and MR perfusion imaging were safe, and MR was non-inferior to FFR, to invasive FFR. And the number of revascularization procedures was significantly lower when it was guided by MR perfusion imaging. So how can we put this into context with all of the other studies? So the ischemia trial and the other evidence that I've presented, where does it lead us? Well, it leads us along the well-trodden path of the evolution of medicine for most diseases, that we go from large access surgery to keyhole access operations to tablets and then eradication. We go from control of symptoms to eradication of disease. And this is why I stress research is so important. It is an essential component of medical practice, and it's for clinicians to make sure we take part in that research so that we can go, as I said, from control of symptoms of a disease to ultimately eradication of disease. Ischemia, Courage, Orbiter, and MR-INFORM are merely signposting us for the direction of travel for atherosclerotic cardiovascular disease. They are nails in the coffin of early invasive management. So 5 years ago, all of these patients in this country would have coronary angiography. Now they're undergoing stress MR or CT, and they are optimally being managed. And I'll show you data of how that is being put into effect in the UK. And it's very similar to how percutaneous coronary intervention is the first nail in the expansion of open heart surgical revascularization. And this is data in the UK from the NICOR BSIS database. So if you look at the left graph, the clinical syndrome, you can see that PCI has increased for acute coronary syndromes, but in the yellow, but for stable angina, it has gone down and continues to go down. If you look on the right graph, the total PCI and isolated CABG, you can see that in the pink, the numbers of PCIs in the country has continued to increase, whereas the numbers of coronary artery bypass graft surgery has decreased and has stabilized over the last 5 years. So I want to take this opportunity to think about where the natural history of progress of invasive medical procedures and put it into the context of stable angina. And we can look at examples from prostate surgery, peptic ulcers, and renal calculi. So we started off with prostate surgery when I was a house officer in surgery. All day long, I clerked patients who were undergoing prostatectomy operations. Eventually, you went from surgical to percutaneous. You had radiotherapy guidance, you had small bore keyhole operations, and then you went to medical treatment now, and hardly anybody comes from prostatectomy. And if you put this into the context of stable angina and atherosclerotic disease, we've gone from surgical revascularization, CABG plus optimal medical therapy, to percutaneous, where it was primarily angiographically led investigation, and then revascularization and optimal medical therapy, to now it's percutaneous, where you have MR stress or CT guided investigation, followed by a PCI in a much smaller group of patients with optimal medical therapy. As pharmacology improves and increases potency, and we've seen with reduction of inflammation, we've seen with PCSK9s, there is a hope that we will get regression of the disease and that we will just have medical treatment of atherosclerotic cardiovascular disease. So we've gone from resource intensive, high cost treatment to hopefully less resource intensive and to lower cost treatments. So in summary, panel, the ischemia trial is simply one chapter in an ongoing story of disease management to disease eradication of atherosclerotic cardiovascular disease. It is important that if we're going to accurately interpret the ischemia trial, that we need to have knowledge of the previous chapters in this story. And that's what I've hoped to give you in this lecture. But the direction of travel is clear. It is that the medical profession is ultimately leading to the long-term goal of atherosclerotic cardiovascular disease eradication. As I said to you, targeting inflammation, targeting lipids, and then targeting symptoms with very powerful medication. For now, stable angina with severe ischemia can be safely investigated using non-invasive means and safely treated with optimal medical therapy. And what the ischemia trial tells us is that we can reduce investigation and treatment. We can from 96% to around 26% of patients who will require invasive revascularization. What does this tell us? Well, if we can adopt this approach, it's not only safer for patients to have less invasive procedures, but it's also more cost effective for the healthcare economy. Thank you for your attention.
Dr. Raghu, you have to unmute yourself.
Thank you, Dr. Zaman. Once again, I would like to express my thanks for such a lovely talk, very concise, giving us some idea of what we are headed for, the future directions, especially in trying to eradicate rather than just treat with an oculostenotic reflex. try to get in more medical management, treat more patients medically and less patients invasively. If Dr. Zaman can hold on till the end of the session, we'll take the questions after Dr. Rajiv Agarwal also finishes his talk. What do you say, Dr. Kasliwal? Do you agree with me?
I think that sounds good. That
Yeah,
we
so
take the questions after that, and Dr. Manish Bansal has also joined us, so he will also be able to participate in this.
yeah.
Thank you.
So I invite Dr. Rajiv Agarwal to give his talk on the statins. What is the current role of PCSK inhibitors? And I'm sure we'll all be enlightened in better management of lipid disorders now. Thank you, Dr. Rajiv Agarwal. I hand over the mic to you.
Yeah. Thank you, Dr. Kasliwal, Dr. Raghu, Dr. Jaman. It's a unique opportunity where chronic stable angina and acute coronary syndrome, they are back to back. And I think I'll philosophically fit in where Dr. Jamal set in, that it is a disease over a time as we evolve to medical management. From invasion to medical management, I strongly believe that coronary artery disease is a metabolic disease. And if we want to eliminate or stabilize or hibernate the disease, the medical approaches are probably going to be superior. I have a little bit modified Dr. Kasliwal's topic, and I have used intensify ezetimibe. That means you have to MIBE the patient or MABD the patient. And this is in relation to acute coronary syndrome, but can be broadly applied to chronic coronary syndrome. As you know, acute coronary syndrome is a volcanic disruption. Sclerosis. We have a lot of understanding of chronic coronary syndrome, which had been revolutionized by courage, orbit, and we have to be courageous enough to practice this. So let me start the journey on ACS layout. Many of us believe that acute coronary syndrome is a single entity. To my mind, it's a very broad heterogeneous group. There is a patient who has had the first event. There is a patient who had a repeat event in post-acute coronary syndrome patient, PCI or CABG, or he's a part of polyvascular disease, repeat event in less than 1 or 2 years, younger age, that means he's going to spend a lot of time in the atherosclerotic disease, he becomes automatically a high abundance of comorbidities. So that is how I look at acute coronary syndrome, that how we deal it. The treatment protocols in chronic coronary syndrome are a lot of discussion, evolution, but in acute coronary syndrome, it is invasion and whenever possibly mechanically. What is the core issue? Why Dr. Kasliwal has given this topic, especially defining acute coronary syndrome? The reason is the changing goals. The goals are very tougher, difficult to achieve, but they are realistic. There is no change in goals between 2016 and 2019 in low risk patient, but rest of the categories, the goals are decreased. And if you look at the high risk patient, the first word written is less than 50% reduction. That absolve us from the number game, that what is the number, but we have to achieve minimum 50% reduction, and mind it, it is less than 50%. And in very high risk patient, again, the goal had been remodified to 1.4, something around 55. And in patients who have recurrence of event within 2 years, the goal had been 5 millimole, talking about something like 38 or 40 milligram per deciliter of LDL. So when we talk of these, then we realize that drugs, single drug like statin alone is not going to my journey. The Epidemia in acute coronary syndrome is class 1A indication. If you're not able to achieve this goal, then ezetimibe is there, and you have to monitor these patients in 4 to 6 weeks. What is important to know that this is a recent study which was published in Journal of Atherosclerosis in 2020. I'm not talking of historical perspective. Even in countries like Japan, Colombia, Germany, and Philippines, roughly 1/3 of the doctors are just ignorant about the targets. And that is a double whammy, that we, on top of it, ignorance, physician inertia, that we are not knowing where we have to go. The story of acute coronary syndrome started with Improve-It trial, which combined simvastatin and ezetimibe. Mind it, this is acute coronary syndrome patient, but these patients were within 10 days, they were not at 0 hours. So we had been vague in defining our patient population. Even in modern day trials, the of the drug therapy is not started in hours and days. The recruitment is in Improve-It within 10 days. And look what has happened. If there is no polyvascular disease, after 7 years of follow-up, the NNT is 59. If you have polyvascular disease, NNT is just 11, an absolute risk reduction of 9. And all of you will agree that I don't know anything in cardiology with absolute risk reduction of 9% with anything I know of. So if patient is high risk in acute coronary syndrome, we achieve enormously over a period of time, and it should not be talked about that it will happen in days and weeks, but it happens over a period of time in terms of years. Atherosclerosis cannot be managed in days and weeks. It not only modifies the first event, second event, third event, fourth event. So as the patient gets sicker, that means patient who had 4 events, the p-value becomes. Over a period of time, all these therapies, they pay you more dividends like your FDs. If you retain them, your mutual fund for longer period rather than encashing them in short period of time. The Odyssey is again acute coronary syndrome patient trial, and it has revolutionized our thinking about the LDL management. But the problem with Odyssey is patients who were less than 4 weeks in acute coronary syndrome was not recruited. Patients who were more than 52 weeks in acute coronary syndrome, they were not included. So patients after a month, they were recruited, and this trial showed for the first time that in acute coronary syndrome with invasive, active, aggressive LDL reduction, you can have mortality reduction. And look what happens. There is all-cause death is reduced, CV death is reduced, and to many of you will be surprised, even non-cardiovascular deaths are reduced. So this invasive approach, aggressive approach of LDL reduction translated to non. Also, the mechanistic of that is not very well known. If the patients are in totality, the curve bifurcates like this. But if you follow up patients who are followed up in the trial for more than 3 years, then you find the separation is at 1 year and it grows, opens like a crocodile mouth. Longer you follow, better you get. So roughly the trials unanimously have shown that atherosclerosis taming takes about a year or so. Another thing which this Odyssey showed that if despite statin aggressive approach, your baseline LDL remains that, then these are the patients who are maximally benefited than patients who have already achieved something around 80 on statin. So intensification is good, but if the residual LDL is high, then it is the patient who will be benefited maximally. And what this trial showed that if you look at the all-cause death hazard, roughly up to 30 onwards, the hazard ratio keeps on increasing. So maybe we have to have something like 30 in our patients. It reduces fatal and non-fatal. Both kind of episodes are by alirocumab, and that is how we look at this trial. and number of events. In totality, now we have started following not one event, first event, we have started following cumulative events. And now you see roughly about 400 events were less in treated group over a period of 8 years. Again, the same story, what had been shown in Improve It. If your acute coronary syndrome patient is part of polyvascular disease, and polyvascular disease means when there are two vascular beds are involved, then these patients are doing exceptionally well. So look at the graph from top to bottom. There is only one vascular bed, the benefit is less. If there are two vascular bed, the benefit is more. If there are three vascular bed, that means PAD, CVA, and CAD, then these patients are being enormously benefited, justifying that atherosclerosis in these patients have become more or less systemic disease and they will be maximally benefited. LDL, there is another substudy. 50 is the, less than 50 is the appropriate. We talk of less than 50. And what they have shown, three groups, more than 50, 25 to 50, and less than 25. What they have shown that the hazard ratio between 20 to 50 and 20, less than 25 is same. Probably you need not to work for less than 25 milligram deciliter of LDL. So between 20 to 50, that means less than 50 is an ideal value, something around 30 or 40. Then what happens? The outcome in 4-year study, peripheral arterial disease, that means this is a patient who had polyvascular disease. These are 3.5% absolute risk reduction. Then again, 3.5 absolute risk reduction. So the more of polyvascular disease in acute coronary syndrome, open up all your guns and bomb this patient with maximum possible lipid lowering therapy. Look at it with diabetic patient. If the patient is diabetic, the hazard ratio is reduced to, there is relative risk reduction of 16%, absolute risk reduction of 2.3%. That means if there is with data, and there is unanimity that polyvascular disease with diabetes is a very, very high risk patient and is a candidate for aggressive lipid lowering. This is ACC-AHA management strategy. Again, they have shown that patients who are very high risk, they are being benefited more in patients where aggressive reduction is achieved. Low density lipid after adverse aggressive lipid lowering after PCI. I often feel lipidology is most needed by interventionists because they have the highest risk patient. Unfortunately, they don't practice lipidology with the result that they enjoy opening arteries over a period of time rather than killing the disease. And look, what is the US data? This is 2020. This is not Indian data. Indian data has to be worse than this. 70%, 50% patients were not even measured for LDL. And if you look, only 57% patients following PCI achieved less than 70. 43% patients were not achieving goals. And you can see the MACE is directly related to the LDL level. So even in post-PCI patient, unfortunately, interventionists are not practicing lipidology, which is a very, very unfortunate situation because they are in touch with very high-risk patients. And they are the patient who will be benefited most. Recurrence of event in an intervened patient should be taken with some kind of shame and inaction on the part of interventionists rather than recurrence of disease and blame the patient. And look at what they have achieved, that beyond 40, the curve of MACE keeps on increasing. I'm going to show you one very interesting study with a weaker statin, agitamide with pitavastatin. They made it into two groups. One group was given only pitavastatin and one group for intensive therapy, agitamide. And look, the LDL achieved in the two groups. This is a Japanese study, weaker statin, and not achieving even 50, even at 60, you find after 1 year, there is 23% relative risk reduction with p-value of 0.02. So This is a reality. This is a science. This need to be practiced and emphasized that acute coronary syndrome reflects in MACE over a period of time. This is by Dr. Luker, another very innovative trial. This is a placebo-controlled randomized trial. What they did, this is not a guideline recommendation. One group of patients, they give intensive statin therapy, and another group, PCSK9 as step 1 drug. So in a way, head-to-head comparison of intensive PCSK, and what they showed that isolated or step 1 PCSK9 is superior to intensive statin therapy, and you achieve larger number of 75% of patients will achieve less than 70, and roughly about 60% will achieve less than 55, which is the guideline recommendation. And 30 days follow-up, you continue to maintain, you continue to gain in terms of LDL reduction. So yeah, leave aside cost. That is not a consideration at the moment. What we are talking is science, that even people have tried to give PCSK9 as a step 1 drug. In limited studies, I'm shown that it is purposeful. Over a period of time, I have started defining you acute coronary syndrome, the variety of patient. There are several guidelines which can be talked about how we define acute coronary syndrome. The simplest I came across is this score. If you have any one of the 3, the score is 2, myocardial infarction, ischemic syndrome, ischemic stroke, peripheral artery disease. And if you have any one of them, then it is 1. And if anyone having more than 2, you become high risk. That is the simplest score and can be memorized and practiced. Patient is more than 65, congestive heart failure, diabetes, hypertension, EGFR, smoker, LDL more than 100 on maximum statin and ezetimibe, and LDL more than 220. So if you do this algorithm, you know what kind of patient of acute coronary syndrome you are handling at the moment. And this is what it shows, that very high risk patients are naturally at a very high risk. Improve It trial gave us another very innovative way to look at the patient, which is based on biomarkers. I find practically it is less practical, but it's really scientific that if we use these 4 biomarkers, we can still define a high risk, which is an interpretation of Odyssey trial, that if the patient of acute coronary syndrome MIs, qualifying MI in years, less than 2, more than 2. If you have less than 2, your risk is 3.4 times. Number of prior MI is more than 2, your risk is 3.7 times. And residual multivessel disease. That is a very, very important thing and simple thing to do. You are putting a LED stent, and the RCA and LCX is having. Don't treat it as a simple disease. It is a very high risk patient and need to be addressed very aggressively in a couple of years. So spread of the disease is more important than the artery to handle. And the similar kind of data has been shown by CT and ischemia trial. It is not the amount of ischemia which matter. What matters is the spread of the disease. A patient who has got 10% ischemia, a single LAD disease, is a simpler patient than a patient who has got 10% ischemia, but multiple non-obstructive diseases in 3 vessels. So spread of the disease is very, very important. How the guidelines give us the compass, the Indian guidelines, which are published in Journal of Clinical Lipidology, we talk something around risk group of patients who have had recurrence of acute coronary syndrome within a year, while the European guideline defined that time frame as 2 years. The European guidelines define that very high risk patient who has ASCVD, either clinical or imaging or an expression of the disease as acute coronary syndrome, you have to come down to 55. And if you have recurrence, they have gone down to less than 40. It is less than 40. It is not 40. So it is 2BB. So I personally definitely not less than 25, as I have shown you that it is not purposeful. The American guidelines suggest that how to go about. You can ezetimibe, if you're not able to achieve something like less than 55, then add PCSK9. So story is very clear. Acute coronary syndrome, if you have high background atherosclerotic disease burden, these are the patients who need very aggressive lipid lowering, and the algorithm is simple: statin intensification, and then putting these patients on PCSK9. If you put PCSK9 after ezetimibe, it is class 1 indication, but if you put it before ezetimibe, it is class 2 indication. Recommend ezetimibe to be used compulsively in every patient. What are the outcomes? Look at the GLAGO. If you achieve low level, you regress atherosclerosis. We are not pacifying the plaque. We are eliminating the disease. That is why it is, and that aggressive lipid lowering is elimination of the disease, not pacification of the disease. And that is GLAGO showed that if you reduce in less than 70 milligram deciliter on a statin therapy, in GLAGO trial, 81% patients showed a regression. So regression is only possible at very, very low level. And that is the schematic diagram that statin and nivolumab, or statin or PCSK9, you have more regression of the disease. And that is, like Dr. Zaman said, the aim of the treatment, that we have to move from invasion to medical therapy. The real world data, this is not exactly acute coronary syndrome. This is Dr. Kausik's study published probably in August. What they did, they studied what is the pattern of practice in UK. And what they find that 40% of the patient are, roughly 1/3 of the patient are more than 40% risk on. This is not acute coronary syndrome, it's chronic stable angina. So reach criteria, 30% of the patient are very, very high risk. And what they found, that even in Europe, if we look at that, only 18% patient in total achieved the 2019 goals. And PCSK9 in Europe was used in only 1% of the patient population. And what he says, that if you use PCSK9 with ezetimibe or statin and try to achieve 2019 goal, only roughly about 58-60% patients, they achieve the target. So he is of the opinion that if you want to achieve 2019 goal, statin and ezetimibe, they are not enough. And he is very categorically strong that probably all these patients, 2009 ESC guideline goals of less than 50 or 40 or 30 of that kind, you have to use PCSK9. And I think that is why Dr. Kasliwal has written, you have to dial in majority of your patient for PCSK9. I think they need to be mapped. And that is what is the summary slide I could take out from Dr. Kausik's lecture. Moderate dose in statin 2.3, high dose statin 2.16, high dose statin with ezetimibe still not 1.4. If you use high dose statin, ezetimibe and MAB, then 0.8. And if you use high dose statin and MAB, 1.8. And 2019 goal is 1.4. So truly speaking, there is a very little likelihood that you can achieve acute coronary syndrome lipid goals of 2019 without high dose statin and MAB. I'll say we have small body mass, small frame. Maybe in India, in my own experience, I find some patients do extremely well with statin and ezetimibe, but the issue is the numbers, not what you use. But majority of these patients will need PCSK9. And that is what he says in the article. Most patient LDL-C goal of 1.4 millimole would be unattainable with monotherapy, and only 58% will achieve with PCSK9. Maybe we need newer drugs like bempedoic acid, inclisiran, mipomersen, and this is how we are going to tame the disease. The last 2 or 3 slides, the ACC-AHA clinical performance quality measures look at the disparity. Aspirin at arrival, aspirin at discharge, but high intensity statin is prescribed at discharge. That means even the guidelines doesn't force us to statinize or lipid lower all of our patients at 0 hours the moment they enter. The performance measured, they describe that you can give up to discharge. I think of data that what it makes a difference if you start at 0 hours or after 1 week. And that is the kind of thing we look at, how the trialist will give that kind of information. And I, in my all patient, give high dose statin at the moment I receive a patient like ticagrelor or aspirin or prasugrel. So that should be the standard of practice to my mind. And these we can use them and depend upon how you achieve that low level. So combination therapy is needed to achieve 2019 goal. Very high risk patient, the combination should include MAB. Instead of statin therapy, the commandment should be intensive LDL-C lowering to eliminate we can pacify and regress the disease. And I keep showing this slide that let us not be dry cleaners. We should be the healers of the artery. And Dr. Zaman has said, and I agree and endorse him, that the treatment of coronary artery disease is metabolic. And at the moment, the best tool we have is LDL lowering. We should not leave any stone unturned to achieve that goal. And this is what we keep seeing. This is a cartoon I received only yesterday when we go to shops and ask for a kind of something that doesn't have fat and sugar. The sales girl said, we have only napkins with that. So this is the last slide of the presentation. COVID has taught us simplicity, spirituality, plus uncertainty. So thank you very much for listening patiently. I hope I withstood the test which Dr. Kasliwal gave to me, and I delivered what he wanted to deliver. Thank you very much.
Thank you, Dr. Agarwal. I'm sure Dr. Kasliwal will more than support your statement that you more than adequately delivered what he wanted.
Oh, yes, absolutely. Absolutely.
I don't see any questions from the audience. We have a sizable audience, but there have been no questions except for one question in the chat box, which Dr. Zaman has already answered the question. I will read it out. I'm not able to get the chat. Yeah. Santosh Lal had asked a question on what one does when a patient diagnosed with DCM with an LVEF of about 20% undergoes a CAJ which reveals a two-vessel disease with around 90% stenosis in both LAD and LCH. What will be the further plan in this case? And Dr. Zaman wrote back saying stress MR to look for viability. If present, then revascularization of discussion with the heart team. So would you like to add anything more on that, Dr. Zaman? I mean, would the STITCH trial give us some indication in this kind of a situation as what to do and how to proceed? Of course, some evidence of viability is a must. If it's totally scarred myocardium with an EF of 20%, one would be putting the patient to a considerable risk in attempting to do either any form of intervention.
Correct. Yes. No. So the STITCH trial tells us that if there's viability, the patient will benefit. I think at 20%, many surgeons will feel uneasy about taking him for open heart surgery, and it will depend on the other comorbidities. So I think in context of what's already been presented this morning, I think aggressive optimal medical therapy. And then viability is essential, because if there is viability, there is a chance that that ejection fraction of 20, we may see some improvement subsequently.
If I might ask a question of Dr. Zaman, we know that you've very lucidly shown us that both ischemia, courage, and orbit have all shown that in stable angina patients, invasive cardiology doesn't really greatly alter the MACE or the longevity of the patient. However, are there some exclusions like an ostial LAD lesion or a left main lesion before you attempt to segregate them into the optimal medical therapy in such patients?
Yeah, so a very good point. So it's very important then to stress that all of the studies that I've talked about, courage, orbiter, ischemia, have all excluded patients with left main stem. So if you had left main stem of greater than 50%, these patients were excluded. So the trial data excludes those. Now, you did have ostial LAD disease patients in these studies. So once again, exclude left main, exclude acute coronary syndrome. But what the ischemia study shows is that you can take high risk stable angina patients and manage them adequately with optimal medical therapy and non-invasive investigations.
Thank you. I have another question, Dr. Zaman. Since there are no questions in the chat box, I thought we'll keep the session rolling with a few questions from my side. I'm giving you a hypothetical situation. I'm a cardiologist and I have a good 1.5 to 2 hours of doubles tennis in the mornings. And I'm very passionate about it. And suppose I say I have 70 to 80% stenosis in the LAD, and I am getting angina at a particular work threshold, say while I'm playing, while serving, or when I'm running after the ball. Now, would I not be a case for an intervention, despite the fact that these 3 trials have shown that an intervention is not going to change my longevity, change my MACE events? However, as far as quality of life is concerned, I possibly with a stent in my LAD, I would be able to play better without the fear of a sudden cardiac death or collapsing on the tennis ground.
Yeah, so that's a very important point. So there's no relationship between the symptoms you're getting and your risk of a further event. So the risk of a further event is, as Dr. Agrawal said, it's like a volcano. And to predict when that plaque will rupture is not within our means at the moment. So the key thing to answer your question is controlling your symptoms. And the first stage of controlling your symptoms is with optimal medical therapy. That's what the trials tell us. Clearly, quality of life is important. So you have to be on the maximally tolerated, and that's the operative word, maximally tolerated medication. If the maximally tolerated medication controls your symptoms, allows you to play your sports, do your activities, that's the best option. If optimally tolerated medication does not, then you're looking to do investigations. And then if those investigations show ischemia, confirm ischemia, then of course you would go on to invasive revascularization.
Yeah, in fact, if I remember the Courage trial, one of the caveats that was pointed out was that it did not, quite a lot of patients ended up in a crossover to invasive evaluation and further invasive treatment. So I suppose quality of life would ultimately lead us in many of these patients to go in for a stenting procedure.
Yes. And I want to emphasize that what the studies are telling us is not that there is no role for invasive management. It is what they are telling us is that invasive management has a role, but if you follow the optimal medical therapy pathway, you reduce that invasive management from ischemia from 96% to 26%. So you can give examples of cases that undoubtedly would benefit from invasive management. the point of these studies is that instead of the majority having invasive therapy, you now have a minority who will benefit from invasive therapy, and that we are in a better position to identify who that minority of patients is that can benefit from invasive revascularization.
There is a couple of questions from the audience. When patient presented with ACS and had 260 milligrams of LDL, after 6 weeks of high intensity statin, LDL became just 160 milligrams. So whether we need to add ezetimibe or PCSK inhibitor, if it is not available in Nepal, how to manage, if not decrease with ezetimibe addition? Dr. Agarwal, I'll pass on this question to you.
Yeah, it's a very common question, and it has got a simple answer. That, and as I told you, try.
Dr. Agarwal, your voice is breaking. We are unable to hear you. Hello. Hello. Dr. Kasiwal, are you able to hear me?
Yeah, I'm able to hear you loud and clear.
But
yeah.
I'm not getting Dr. Agarwal. He dropped suddenly.
Oh, he's back. He's back.
I think he's back. He's back.
Yeah, I think it's a very genuine question. And patients who are not tolerating statin, they have to be combined with ezetimibe. And I emphasize that majority of the patient will need ezetimibe. Very few patients will be happy with achieving these goals with statin alone. And maybe you reduce the dose of the statin molecule. If you have a luxury that patient can afford it, then there is no question.
I have a question from the audience for Dr. Zaman. What percentage of patients had a crossover in Courage and Ischemia trial? Dr. Sashikant Pautam wants to know about that.
So the Courage, I think, was just under 17% of crossover. Ischemia was, if I remember correctly, was around 12% had crossover. But you will get crossover. So once again, I want to emphasize that the point of these trials is not to say that there is no role for invasive. There will always be a role for invasive until we can eradicate the disease. The point of these trials is to get practice to have optimal management that reduces invasive management. It's not currently eradicated. Yeah.
I have a question for Dr. Agarwal from the audience. Some ACS patient has just 80 milligrams of LDL. Here, do we need to reduce it by 50% or make it just less than 55 in 4 to 6 weeks period?
50% is the first mandate. And if it is
yeah.
I have a question to Dr. Agarwal. Dr. Agarwal, we knew very well that reduction of cholesterol way back in the 80s when the Forest trial had come, that reduction of cholesterol brings a reversal of the atherosclerotic burden and also the stenotic lesions. Yet we went through 90s and the first part of this millennium and also the second part, mostly trying to treat these lesions with stenting and whatnot. Suddenly in the last 2 years, there's so much of awakening. While ezetimibe came to use in the first part of this millennium, we suddenly find that we are increasingly using it only in the last 2 years after the latest guidelines, which suggested LDL should come down to less than 70, and the Indian guidelines, which suggested that it should come down to less than 50. What do you think has hampered our adopting the idea of reducing LDL very drastically? Why has there been so much of inertia, nearly 20 years, 20, 30 years duration in passing on all the clinical work in trying to reduce the LDL levels to as much as possible?
I think you are right. It took a lot of time to communicate to the community, that doctors community, that we need to have low LDL. If the LDL is 30 to 40. studies, if you look the genetic studies, if you look Dr. Brownstein and Lowndes, which I keep Nobel laureate speech, they predict 25 to 40 milligram of LDL what you need in way back in 1985. Look at the Jupiter. This was a primary prevention trial, showed that up to 55 you do good. So there is so much of literature available that LDL low is the essence of treatment, but somehow we are scared of its side effects. Somehow we are not willing to in lipidology is very little, unlike diabetology.
Yeah.
We are not trying to titrate of time. Majority of us are giving a blanket dose level achieved.
Yeah. Well, one thing I would like to add also that we haven't talked about is lifetime exposure. So
Yes.
not only is lower is better, but the lower, the longer is better. So you should start treatment early because there is now the concept of lifetime exposure to LDL. So not only should you achieve these targets that Dr. Agarwal is talking about, but you should achieve it as soon as possible so that the lifetime exposure is reduced.
Can I
Dr.
hand
Raghu,
over
may
the
I say
mic
something
to
here?
Dr. Kasliwal now so that he can add his
Yeah, no,
comments?
I'm totally in consonance with Dr. Agrawal and Dr. Zaman when they say LDL years have so much to do than just the LDL levels. I think it all it stems to the fact that this knowledge has to be more widespread. We have to empower our people and say this is real world data. This is data on real world. I mean, if you're letting a person with post PTCA, post bypass with 80 milligrams per deciliter, obviously he's going to come back. I mean, there is no doubt about it. Also, one good question that was asked by Mr. Dr. P.C. Pava was that does CAL score relate to atherosclerosis? And I think this is where it all begins. If you have a CAL score of 0, you're in fairly good shape. But
Yes.
if you have CAL score anything above 0, anything above 100, and if it's a soft plaque, you've picked up disease before it actually was even manifest. So I think this field, and I think I must congratulate both the speakers and Dr. Raghu. You've done a fabulous job of, I mean, they have brought forward right from Jupiter to ischemia and put everything in perspective, right from acute coronary syndromes to stable angina to those who are asymptomatic. And I think this knowledge, such a symposium should be repeated after every so often till it comes to because we have so much disease in our country. I mean, South Asia, as epidemiologists keep telling us, but I think that all clinicians, all of us should actually become clinical epidemiologists. If we save 10 people a week, can you imagine the kind of impact we'll make in 52 weeks? And if 10 colleagues of ours do it, it's huge. Then it doesn't just become a figure or a statistic, then it becomes a reality. And so, Dr. Raghu, for you, for the last word.
Oh, shall I invite Manish Bansal to speak some words here? Any questions that you might have or thoughts to add?
Thank you so much, sir. I had some questions, but they have been answered during the discussion. And I agree with Dr. Kasliwal that these two were really wonderful talks covering two different aspects of coronary artery disease. Dr. Zaman told us that in chronic stable CAD, we don't have to jump onto invasive management immediately. Most patients can be managed with optimal medical therapy to begin with, and if their symptoms are not controlled or those who have high risk features, they only should have invasive management done. And Dr. Agrawala very beautifully highlighted role of intensive lipid lowering in reducing the risk of recurrent event in patients with acute coronary events. So very wonderful and insightful talks from both the speakers. Thank you so much.
Thank you, Dr. Manish. And I again thank Dr. Zaman and Dr. Agarwal for the fantastic talks. Dr. Zaman mentioned about MR Inform and how MR coefficient imaging is coming of age. Unfortunately, I don't see much it being very commonly used in our country. we still are using a lot of CT, and lately, even my own practice has changed to getting a CT angio done before I even consider a invasive coronary angio, more because I get some idea about the calcium score and the plaque characteristics, apart from, of course, getting an idea about the anatomy itself. However, I don't have much experience. Our lab does not do MR perfusion imaging. I do not know whether Medanta is using MR perfusion imaging or not, but I suppose it is the future. I'm sure it will come to our country also, and we'll be increasingly using it. So we had two wonderful talks which emphasized how important it is to understand stable angina pectoris, how important it is to understand that the control of the disease is not just to put a stent, but actually to remove atherosclerotic coronary vascular disease by using appropriate lifestyle modifications, and also the use of optical medical management, with which Dr. Zaman took pains to show how in at least two trials, it brought down, understanding this thing has brought down our use of invasive angiography from 71 to 26%, and how the patients are benefited because of that. Dr. Rajiv Agarwal, thank you again for a wonderful talk. I think we should have this talk more and more often, because it is still unfortunate that in our country, people do not go beyond 20 milligrams of atorvastatin or 10 milligrams of rosuvastatin. When I see a wide gamut of prescriptions from many of the practitioners, even cardiologists, so to speak, we rarely see ezetimibe mentioned. And while even a MBBS doctor has at the tip of his tongue all these statin trade names, I'm sure if you ask him suddenly, can you tell me one trade name of ezetimibe, he will not be able to answer. So that shows really what we are at today. And it is unfortunate if we have a young patient with a high LDL after an MI and he is not on ezetimibe. Of course, PCSK inhibitor, it's going to take a couple of years before it's really going to come to India in a great way. I suppose in Delhi and in Bombay and in those populations where money is not an important factor, there may be a few patients who are on these medications. But for the large majority of the population in this country to get that, I'm sure it's going to take a little while. But in the meantime, at least we can do our best by using both ezetimibe and high-dose statins and try to bring down the LDL as much as possible, so that we can reduce recurrences of ACF, which most people, when they put a stent, don't even bother to think about. Thank you once more, Dr. Kasliwal. I am really, really proud when you called me. I felt I was on the 7th heaven of delight that you should include me in such a program. It was a very, very learning program for me. Thank you very much, Dr. Zaman, Dr. Agarwal, Dr. Kasliwal, and Dr. Manish. And I'll close with this. Thank you very much.
Thank you very much. Thank you, everyone. Thank you, everyone.
Thank you, everybody. Bye-bye. Bye-bye.
Thank you, doctor. बेटा अपना दूसरा वाला ले ले इसमें। हाँ, ले लीजिए। हाँ, हाँ।